Welcome to the Language Access in Pharmacy webinar, presented by Envision America. The following discussion is hosted by Sharla Glass. The featured speakers for today's discussion include Joana Tudela, who discusses how pharmacies can utilize their environment, software, and processes to remove language barriers. Kristen Beiers-Jones, who discusses how she and her nursing students successfully passed a dual-language prescription labeling bill in Oregon. Assemblyman Duy Nguyen, who shares with us how he and constituents work together to overcome the language barriers in his Las Vegas district. And Dr. Kramer, who highlights the many ways that student pharmacists and student ASL interpreters can practice together to improve the patient experience for those who are deaf. Contact information for each speaker can be found in the description below. We hope you enjoy today's discussion.
But I'm really excited to have this group of panelists. I've been really privileged to work with all of these people in the last few years, and it's always really amazing to find other people who are passionate about the same thing you're passionate about. And so I'm just excited to share all their knowledge and experience with everyone else who's watching the webinar. So just if you're not familiar with Envision America, I just want to introduce our company. We make accessible prescription labels. We make audible, large print, Braille, and now dual language prescription labels. So pharmacies can utilize our software and labels to accommodate their patients in a wide variety of ways. And in our process of working with patients and pharmacists, we always are, interested in advocates and what they're working on. And so Joana, Kristen, Louis, and Stephen have all been some people that I've worked with. And I'm, again, so excited to have them here today. So we're going to just allow each of the panelists to speak for 10 or 15 minutes about their personal experience and their professional experience with language access in the pharmacy setting, and what kind of advocacy they've been working on. So we're going to start out with Joana. She has a background in translation and interpretation. She also has a master's degree in public health, and she is really specializing in advocating for linguistic inclusivity in patient pathways. And so she started Culturalizing Access. Yeah. And so a great company that can help healthcare institutions do that. And so, Joana, do you want to share a little bit about your experience and your advocacy work?
Thank you, Sharla. Hi, everybody. Can you hear me all right?
Yep.
Awesome. Hi, everybody. I'm very excited to be here with all the other panelists and for the opportunity to, share my story and what I'm doing with language access through my agency. So as Sharla said, my name is Joana Tudela. I am the founder and senior trainer and consultant for Culturalizing Access. And what we do is we focus on improving language access, mostly within the healthcare system, but we also work within other industries. But we really focus on the consulting and the training aspects. And I want to share with you a little bit of how I got, how my journey got me to, developing and creating this company. It was really more of a necessity and a moment that I had that I was like, nobody's doing anything. This needs to change. Nobody's doing this, so if not me, who? If not now, when? Kind of thing. So that's kind of where life brought me. I moved to the U.S. when I was 18. I didn't speak barely any English, so I was a limited English proficient. Here, I came by myself, so I had to figure out how everything worked in the United States, not just the language, but everything, right? And after I learned English, I went to college for medical lab sciences, and then I decided that the lab work wasn't for me because I wanted to go outside and talk to other people. So I went and did a master's in translation and interpretation. And I mostly worked in the healthcare setting for 3 to 4 years. And then I transitioned into education. I've coordinated and I still teach interpreters, interpreting programs at a community college level just to kind of train mostly in healthcare and human services. And then I did another master's in public health, which led me to start working directly with providers and training them on cultural linguistic appropriate services and other ways to reach within language access to BIPOC and vulnerable populations. And it wasn't really that what led me to build my company. It was mostly because my mom moved to the US 5 years, a month ago, 5 years. And she got really sick when she got here. And I had to take her to the doctor several times trying to figure out what was happening. It was very frustrating that even though I'm in New Jersey, you know, very diverse, one of the most diverse states, it was always a barrier to find an interpreter for her. Even though I took the time to, you know, when I make the appointment, call and tell them that she needed an interpreter. Then I would confirm that we will be there and we needed an interpreter. And then I would walk there and there was no interpreter. And I always ended up interpreting for her because it was just very inconvenient for the providers to provide the interpreters, or they would have to make her wait much longer. They even told me like 1 hour to see if they could find somebody, or I had to use my phone, my personal phone, to call their language access services to provide the interpretation. So it was like a lot of different things, but really what got me to the point of this is enough was when I took her to do a PET scan, and in the room while she was getting changed, there was a sign in English saying, you know, if you have special underwear, antimicrobial, anti-odor, any type of that, please let us know because this can cause severe burns. And of course, the sign is there because something happened. This is not a normal sign that is at the changing rooms of, you know, radiology. So something obviously happened, but it didn't happen, you know, strongly enough that they thought, let me put it into another language like Spanish or Hindi in a location that 50% of the population in my county speaks another language at home. So I got very frustrated because I was like, okay, so if I wasn't there and my mom would have that type of underwear, she would have gone, you know, severe burn. Like, this is not acceptable. So I wrote a 3-page letter to the hospital telling them all the things they're doing about not being compliant and things like that. And then the pandemic hit, so nothing really has been done on their end. But that was the moment that I was like, okay, we need to change this. This is a systematic issue that is happening at all levels. And that's when I was like, okay, so I feel like I have what it takes to do this. So I've been an LLP. I understand their struggle. I've been a caregiver. So I understand that struggle. I've been a provider, an interpreter. So I've been all 3 sides of the intercultural communication setting. So I feel like I really understand what everybody's strength and, you know, struggles are. So that's when I decided to create language access, culturalizing access, I'm sorry. And what we really do is we really focus in the implementation and making sure that organizations are compliant. So we do a very thorough assessment, which is, I'm going to move into what we do, but also what I invite all of you to do and see if your organization is doing as well. So we do a deep assessment on, you know, the language needs, not only by the demographics, but are you doing walkthroughs? Are we doing focus groups that we're inviting LEPs and bilingual employees to really see what's happening within our organizations, what's lacking? Because a lot of the times, now we're moving into, you know, having advisory groups that include patients. Well, we tend to forget a lot of the LEPs, right? Because it's just inconvenient that we need an interpreter there. So we forget their very unique experiences within our organizations. And with that, we develop a plan, a language access plan, that we make sure everybody has SOPs that includes training, hiring bilingual staff that is, you know, tested, because we all hire bilinguals, but we kind of forget to make sure that not only they speak the other language correctly or at a level that is professional, but also that they know the medical terminology. That's very important. So some of the times we don't even test for that. And we see that a lot throughout all the organizations, no matter if it's a small clinic to pharmacists, anywhere. And then with that, we support with the implementation that also includes training on how to work with interpreters, building trust with LEP patients, understanding the Latino patient. And then once everything is settled up, we support the organizations to create a outreach campaign to inform the communities of, you know, what we're doing. And why I'm here today with a pharmacy was because we tend to forget pharmacy a lot. When we talk about healthcare and access, we tend to, you know, everywhere. We always focus on the provider-patient experience, and everything that goes before and after, it's kind of forgotten. And the pharmacy is one of the big ones. And that's where I see a lot of barriers, not only for Latino patients, but all LEPs, including the blind and the deaf communities. So we go into our pharmacies, and culturally, there's so many barriers. Last names, right? Latinos, for example, I'm also Portuguese, so I have 3 last names. Latinos have normally 2 last names, and the system is not set to have more than 1 last name. So we encounter a lot of issues as the provider. Let's imagine the patient is called Luis Sanchez Martinez, right? So the health insurance says Sanchez Martinez, but the doctor says the information as Mr. Martinez, but he introduced himself as Mr. Sanchez. So we're talking about 3 different names, and we can't, figure out what's happening there. And in addition to that, a lot of the times pharmacists don't have language access services, so that we can communicate not only with the pharmacist, but with the tech to explain what's happening with our names, with our date of birth, with whatever issues we're having with the insurances. So it's very, very frustrating for an LEP to go to a pharmacy, because unless everything is straight to and you just get your medication and leave, there is not an opportunity for you to ask questions. There's not an opportunity for you to fix issues that might have it, that might be preventing you from getting your medication. So that's one of the big things I always advocate, is like, let's look at the before and the after, especially that after the follow-up with the patients and going to the pharmacies, because we see a huge lack of treatment adherence. And that's because they can't get medication. It's so frustrating that most of the time they have to, wait on somebody else to get their medication because it's just so complicated. And I think that's pretty much my 15 minutes of, a little spill of kind of what we do and why we think that language access is very important, but especially also including the pharmacy. So Sharla, I'm gonna.
Thank you so much. Yeah, so one of the solutions there that I hear you saying is that if the pharmacy software had fields to allow for multiple last names, that would be one like standard that we could integrate, and that would help. That's our first practical solution there. And signage, right? So thank you so much. I mean, I just think that your story is so, it's so real and inspiring, because inspiring for people to want to make a change, because, the dangers that are there, and just the whole access issue. Just, can we make this easier? Because it's already hard to go through the whole process. Healthcare is very hard to navigate, even when you know what you're doing. So, okay, great. Thank you so much. All right, next up is Kristen Beiers-Jones. She is Assistant Professor of Clinical Nursing at Oregon Health Science University. She teaches classes in public health nursing. She was awarded in 2019 the Policy Champion Award from the Oregon Public Health Association for her work in SB 698, the SMART law, which means Safe Medications for All requires translation. So she's got several years under her belt trying to get this law also adequately implemented, which is a challenge after the fact. It's hard to get a law passed, but getting it implemented is hard too. So Kristen, you want to share a little bit more about that whole process and what you're working on?
Sure. Thank you so much for having me today. This is such an important issue, and you're right, Sharla. It's always fulfilling to meet other people who care about these issues. So yes, I'm Kristen Beiers-Jones, she, her pronouns, and I teach, as Sharla mentioned, population health, public health, community health, nursing, and I'm a clinical faculty. So my students are placed in communities, and my particular program is called ICANN, Interprofessional Care Access Network, which means that students are placed with me in the refugee and immigrant communities of Portland, Oregon. And what that entails is that they visit the families, that they manage a caseload of families. They visit them in their homes every week. And one of the important things that they do is medication reconciliation. One of the first things we're doing when we're assessing a patient that has been referred to us is, show me your medications. Let's take a look at these. Invariably, somebody comes with a big bag of medications. They dump out on the table or the floor, and we start going through them. And we very rapidly discovered that there were many, many medication errors. 95% of our patients did not speak or read English. And these medication errors cause some really dire consequences. Emergency room visits, multiple appointments with providers, people whose chronic conditions were just not being treated because they were not able to take the medications the way that they had been prescribed. And I would say that most of our patients really wanted to do, whatever the prescriber was suggesting, but they just couldn't read the medication container. So we realized that this is a big problem. And in fact, let me just share two stories with you to illustrate this more. One of them is a woman from a Middle Eastern country, a refugee. She remembers a bomb going off in her city that released a blue powder that resulted in everyone in the family having asthma. They didn't have asthma before, now they have asthma. So she's managed to get her family with 5 children to Oregon as a refugee. And the kids have been in and out of the emergency room. One of them had been hospitalized. So we were referred to go out and visit her. And we discovered that, she had her own medication. She had the medications for 5 children. There were multiple errors, including mixing up the emergency inhalers and the maintenance inhalers. And she was horrified when we pointed out that she had not been giving the medications the way she should have been. This is a woman who was highly educated. She spoke 5 languages. This was not a matter of low health literacy. She had high health literacy, but she just didn't read English. The sadness of this mom when she realized her mistake really impacted me, because I realized it's not just a matter of medication safety and preventing hospitalizations, but just, her assault on her dignity, her trust in the healthcare system, really, really inspired me to want to do something. The other really quick story is a young mom who delivered her baby at one of our hospitals. She also was a refugee, and she, after she delivered the baby, she was sent to the pharmacy to pick up medications. And I have to believe that the pharmacist did the right thing, as well as the legal thing, which is to call an interpreter. And, but she, by the time she got home, she did not read English. She had a bag of medications for herself and her baby. She couldn't remember what the interpreter had said. This is a woman who just gave birth. She's exhausted. She did not remember what was told to her at the pharmacy. And she had medications that were not in her language. So she did the safest thing she could think of, which was just to not take any of the medications or give any to her baby. And you can imagine that this was problematic. So these are just a few of the many stories I have, and it really inspired us to look into this issue. Doing a literature research, we found that the rate of medication errors is over 2 times higher for folks with limited English proficiency. There's also, increasing literature about the health outcomes of somebody who does not speak English in our country. We looked at the laws, and we found that only California and New York had any laws requiring pharmacies to provide translation. And that got very complicated because the Civil Rights Act makes it clear that all healthcare providers, including pharmacists, who are receiving federal funds, need to provide language access. But what does that mean? You know, most people realize that this certainly meant interpreters. You need to call an interpreter. But the idea of translation was not as clear. And we talked to many lawyers who agreed it's not that clear. So we thought, well, we need to pass a law. We need to do something in Oregon. So we started meeting with legislators. And, you know, I will tell you the most common response when we told legislators that people are going home with medications that they don't know how to take and can't read the bottles was, well, this is a no-brainer. We need to do something. And so it was our first foray into the legislative system. Everyone told us that, you know, it probably would take a couple sessions to get something passed. But the response of our legislators, and bipartisan, by the way, was no, this needs to be fixed. So in 2019, we did succeed in passing the SMART law. And I'll just, you know, when we were doing the lobbying, I just want to say that we emphasized three things. You know, medication safety is very clear. And then cost savings, the amount of cost savings to the healthcare system, the hospitals and the insurers should be significant when you think about the cost of medication errors. And then also equity. We certainly wanted to emphasize that. So anyway, the law passed in 2019. Pandemic hit, but you know, the Board of Pharmacy decided to put it on hold because everyone was just so busy with the pandemic response. So it went into effect in 2021. And what the law says is that pharmacies are required to offer translated medication labels in at least 14 languages. And I'm going to pause for a second to, you know, these 14 languages, some people may look at these and be a little bit confused. What we realized, most people say, well, let's just look at the most common 14 languages in the state. But working with refugees, we realized that that many of the languages spoken by communities of the more common languages were not the most vulnerable populations in our state. The most vulnerable were folks who were newly arrived. Their children had not yet learned English to be able to translate for them. They were not in a community of folks who spoke English. So we realized that we needed to make sure that some of those common refugee languages of Oregon, because every state has different populations, needed to be in there. So if you look at the 14 languages, you will see that they certainly included some of the more common languages in Oregon, like Spanish, Vietnamese, Russian, but it also includes some of the refugee languages. The other part to this law is that it needed to be a dual language. We wanted to make sure English was also on the bottle so that EMTs, you know, providers, visiting nurses, family members could read what the medication bottle said. The other two important things is that all pharmacies need to post a sign reminding people that they do have a right to language access. And so this includes interpreters and translation. And that needs to be posted in all pharmacies. And then lastly, we made sure, because of course pharmacists are very cautious people. They want to ensure safety. They worried about the fact that they might not speak the language that is on, or read the language that's on the medications that they're handing out. So there is a liability clause in our law that says if a pharmacist is doing due diligence in getting a certified, vetted translation system, that they will not be held liable. So that's in a nutshell what our law says. So how's it going? So one of the things that is a disappointment to me is that the law did not include any funding. So we were advised to go ahead and get this passed and then come back and look at getting some money. Because, you know, this does, as I mentioned, there's healthcare cost savings for hospitals and insurance companies, but it's pharmacies that are having to pay for these subscriptions to, you know, to translation services, to new software that integrates in the different language. We recognize that there is some cost there, and especially this time for independent pharmacies, this is burdensome. The costs are not huge. The last time I looked, it was, you know, $70 to $100 a month to get the, you know, 14 languages integrated with pharmacies the present software systems. A lot of the chain pharmacies already had the capability. But nevertheless, you know, I recognize that it is burdensome. I wish there had been money that would help some of these pharmacies adhere to this law. The other thing is there wasn't the Board of Pharmacy, you know, wrote the rules, and in fact they have the signage. We provided them with a signage that is available to all pharmacies. They can just download it and post it in the pharmacy. So the Board of Pharmacy, you know, did do that, but it wasn't their job to lead these efforts of implementation. And they're really because of the pandemic, the Oregon Health Authority was not available to do that. So it ended up being this grassroots volunteer team of mine who are just people who are interested in making sure that this happened. It's great that the law passed, but if it's not, you know, used or implemented, it's not too helpful to people. So the good news is that, well, first of all, let me stop for a second. One of the good news is our partnership with Sharla and Envision America, because Sharla really quickly realized that, you know, if we're talking about, you know, access to safe medications for people who cannot read because of vision impairment, well, that also includes people who cannot read because they don't read English. So I was really thrilled, have been over the years, to have the partnership with Sharla. The other partnership that has recently surfaced is the Oregon Health Authority. And as I said, they were really busy with the pandemic, were not available to us when the law was implemented, but now they have been. And we are working closely with them to do an educational campaign for pharmacists to remind them, you know, what is this law? How do we do it? How do we fit the label on a bottle? That is the most common question we have. And let me tell you, there's lots of solutions, such as scroll out, pull tabs, fold over tabs, the talking pill bottles that Sharla's company has. There's lots of solutions to that. And one of my students, her grandmother only read Chinese. She showed me one of her pill bottles that just had this, you know, 2-foot long scroll with the Chinese characters, and her grandmother was so thrilled. So we're reaching out to pharmacists, we're reaching out to prescribers because they can request this when they write that prescription. They can advocate for their patients to have this. And then certainly community members, and especially some of our nonprofits who are representative of people who speak different languages than English. So that's really an exciting development to have that partnership, and I'm excited to see what comes from that. I think implementation will be much improved with that. So thank you. Thanks for having me here today.
Thank you.
Answer
Yeah, I think I agree the implementation thing is probably the hardest part. And we did have somebody in the question and answer, you know, ask like, why aren't people doing that? I mean, why aren't pharmacists doing that? And even though there's like section 1557 of the Affordable Care Act and stuff. And I think like our experience is, but all those laws have an out usually that if this is an undue burden, then you're not required to do it. And then people just claim undue burden. So that definition needs to be tightened up a little bit, as well as maybe funding, like you said, being provided. So, you know, there are some states that have provided some funding for accessible prescription labels for the blind. And so hopefully that trend will increase, and we'll see that, you know, beyond Missouri and Colorado, and maybe go into translation as well. We're hoping the snowball effect. Thank you so much, Kristen, for giving all that background on Oregon's law and the work you guys have done on that and continuing to do on that. So our next presenter, Assemblyman Duy Nguyen, also has been working on legislation. His background is he started an organization, One API in Nevada, in 2018 to empower Asian Pacific Islander Americans in Nevada to get involved in the civic process. And so empowered himself to go to be elected to the Nevada Assembly in 2023. We had the privilege of working a little bit on trying to strengthen the Nevada language law that it passed, but then it never got any rules to implement it. So it's kind of, and so we still have some work to do on that, don't we?
Yes,
But
we yes, we
you
do.
have a unique, your own unique story. So I'm excited for you to share that with us and what your plans are too for the future.
Well, great. Thanks so much. Good morning, and thanks so much for having me on here with such an esteemed group of, advocates and leaders across the country. As Sharla said, my name is Duy Nguyen. I am very honored to represent Nevada in Assembly District 8 in the Nevada State Legislature. And as Sharla mentioned, my election was very recent in 2022, and my first session was in 2023. And taking a step back a little bit, going back to share similarity to Joanna, I'm also an immigrant. I immigrated this country when I was 11 years old, with zero English. So coming into a whole new environment, a whole new culture, a whole new set of rules, everybody struggled. And remember back then when I started school, I did not have an English language program that helped me get ramped up. They just threw me in there and say, hey, sink or swim. And so that was an experience that I would never forget. It definitely motivated me to definitely work harder. And, as immigrant, we were told to just keep our head down and do the work and become a doctor, a lawyer, or engineer. Obviously, I failed because I didn't do any of those three. But at the same time, as I go along in the system and growing up in California and moved to Nevada about 20 years ago, I learned that the system are not designed for the immigrant community and the diversity that this country is made of. So, fast forward to 2022 and 2023 in Nevada, we are one of the most diverse states in the United States. And we have one of the largest growing Asian American Native Hawaiian Pacific Islander community in the country. And there's over, 40 languages that are spoken here just with the NHPI community. And there are so many different dialects within those languages. So it makes things, very unique in terms of our situation. You just can't say one thing and check one language, check one box, and you're done. So and that's just to talk about the AA and HPI community. There's so many other communities here in Nevada because we are the entertainment capital of the world in Las Vegas, where I represent. And there are talents and worker from all over the world that live and work here to support the entertainment industry. And to support all the tourists that come from all over the world. So it makes sense. It makes sense for us to have language access because we're not just dealing with just Nevadans. We're also dealing with folks coming from all over, and whether they're here temporarily for a few days or they're here for a couple of years or they're moving here, there needs to have language access for safety and for safety reasons that all of you have mentioned previously. We want to be able to understand that it is not something that it's going to be a burden. And I think that was mentioned a couple times, the undue burden. I think the other part of the undue burden is that the amount of cost savings as well as the amount of the hardship that folks go through for something that is very easily done. With technology, with modern innovations, so many things that pharmacies are already doing without these laws putting into place. So we do have good partners in the business community. And I know that I work strongly with the Retail Association here in Nevada, and they were very supportive. They were on board because they know that their customers and their constituent truly need the support as well. So I think the challenge for us as a legislator and as a community leader is that how can we truly simplify the process so everyone can follow. So AB 251 was my bill that I worked initially last session, and that was to just kind of simplify the requirement. There was a different bill that was passed in the session prior that required all languages to be accessible in terms of the prescription label. However, that was stuck in the implementation, and we did not get that through. So when I came on in 2023 in Carson City, we work with, Sharla and others to truly simplify that. So maybe we can start with the top 10 language based on census tract, just so that we can start somewhere. I don't think it's going to be too hard to just start with the most demand in terms of the populations and the languages that it speaks. And we have 17 counties in Nevada, and all of us are very unique in terms of our populations and our makeup. So not every county will do similar languages, but let's look at that. Let's look at the very simplistic idea of let's go with the top 10 wherever you are in our state. And that was the intent. The intent, like, Professor Beiers-Jones earlier said, that we wanted to do 2 languages. We want to make sure that it's not only in English, but also a second language on top of that. And for my bill, it was very simple. It was just that one instruction, the usage. And that was the first part that we want to get at, is just how to take the medication. And it's in English, and it's in the language of that patient that they are familiar with. Because like you said, if you are overwhelmed sometime at the pharmacy where you have to wait long lines, you're exhausted, you're sick, and yes, there may be a phone call that you can get translated, but then you are overwhelmed with information. And then do you have ability to write it down? Do you have the ability to retain that knowledge? And then you go home, and of course, life happens and everything goes from one ear to go out the other. So the simple step of just having the ability of saying, take this 5 times a day, or take this 3 times a day, those basic start could help folks remember, oh, okay, these are the things that I got to do first, and be able to just help them alleviate the stress that they have in dealing with these medications. So that's the first step. I'm not saying it's perfect. I'm not saying that we got everything, because sometimes the bottle is very small. Sometimes there's a big bottle, and we've talked about, attachments and flags and other things that comes with the, delivering of these medications. And yes, there's a lot of materials that come with it, but let's just start with that. Let's just start with that step of having folks learning and remembering, take this time of day, take it at daytime, take it at night, take it, before meal, take it after meal. Those are very simplistic start. And I think the challenge that we run into is that there were feedback from my colleagues that it's an undue burden in terms of small businesses that are, pharmacies are still not part of that big chain. And my response to that is that it's a keystroke. It's not truly that complex. And of course, there are resources out there that help them get there. And this is a actual service to the patient. This is how you can take care of your patient. And I think those requirement, like you said, when you spoke to other legislators across the country, it's a no-brainer. This is something that we need to do, because we have to bridge the gap between pharmacists and non-English speaking patient, because it's so critical for us to ensure that these things don't go by the wayside, because it's so simple. And what I learned from Sharla, and also from our retail association folks, is that most of the retailers already have this in place. They don't even need the law to require them. They already are doing it. But our population don't know to ask for it. So they feel intimidated. They feel that, oh, why am I asking for something so simple? And, I even had some opponent says, why don't they just use Google Translate? And I said, okay, well, have you tried to use those kind of devices to translate medical terminology? You will not be very educated with those answers. I mean, that technology is a Band-Aid. It's not perfect yet. And it does not mean that we can rely on that, right? These languages are vetted, and these terminologies are vetted because these software are designed, obviously, with the medical terminology and with already research information so that they can get there. So those are the I guess baby step that we're trying to take. And it was a bipartisan bill. So we have support from both sides of the aisle, and it definitely passes both house. But unfortunately, the governor vetoed it due to some of the oppositions that he received in terms of certain small mom and pop pharmacies saying that they don't have the capacity to adapt and take the steps. And I think we still have that work to do in terms of communicating with these smaller pharmacies, and maybe having conversation with them on how we can get there. And those are the things that we do on a regular basis. And I am a small business owner, so I understand the pain of implementing new things and to be able to remember all that you need to upkeep with your businesses so that you can provide that customer service that is definitely needed. So going into the work of language access, in my professional life, I work in my capacity. Most people think our legislative body is full-time and we do this all the time. No, Nevada, we're still a part-time legislator, so we have day jobs. And, in my day job, I get to work with nonprofit in our community in Nevada to help the Asian American Native Hawaiian Pacific Islander community. And that's through my work with the Asian Community Development Council. And we are celebrating our 10th year anniversary next year. And we just opened a primary care community clinic. And one of our biggest task was to make sure that all of our provider and all of our even staff are bilingual in an Asian language, because we cannot, be the one that says, oh, let's make all these laws. But when we do projects in the community ourselves, we don't think about basic things like this. And again, I want to reemphasize, this is the basic. This is not something that is, on this big wish list or something far-fetched. This is basic, because if folks don't understand how to take care of basics needs, we will not be able to do anything else. So those things are critical for us to be able to serve the underserved communities. And those are some of the challenges that we're still facing. Is because, yes, we still running into a situation, like it was mentioned earlier, that there might be languages that are not the top 10 that needs that support. And of course, we have to be able to find ways to connect those community members to our resources. So at the end of the day, we need to make sure that we continue to engage in conversation with our community leaders and even caregiver and patients themselves, because a lot of times folks feel like they don't have a voice because they don't know how. And learning through this process and working through this last session, what I learned was that I needed to do more in terms of making sure that the everyday people get a chance to weigh in on this issue. I think people assume that the lawmaking process sometimes is for a certain number of people, and the rest of the world just sit by and wait for things to happen. And that's not how it works. We are still a very open and inclusive society where we get to have our voice represented through the citizen legislative body like ours here in Nevada, and be able to do the work of ensuring that all voices are heard. So, not just in my work with the pharmacy prescription language bill here, but in all of my work in terms of our health and human services arena, in terms of our education, in terms of our growth and infrastructure, we have to be able to not take a few steps forward and then have to go back a few steps backward to fix things that we could have done from day one. And language access is very much on the forefront. And, when we talk about language, we're not just talking about just different languages that people speak. We're talking about, everyday terminology to complex terminologies, because not everybody understands that the same way, and how we can reduce those barriers, not just in the medical field, but in everyday life, so that we can be able to navigate every life easier, because, of course, healthcare is the root of everything, and we want to make sure that that's something that we continue to work hard and make sure that everyone is included in the process. So again, want to thank Professor Beiers-Jones and Sharla last session, where they came on and supported my legislative process in terms of getting AB 251 through both houses. We, again, have more work to do in the upcoming session, and our work is not done yet. And I plan to reintroduce similar steps to ensure that we continue to get engaged and get innovative in our solutions, so that we can continue this and be able to help a lot more people.
Awesome. I'm looking forward to it. And thank you so much for sharing all about your journey. And I'm curious, if the new Section 1557 rules mandating 15 languages is going to make a difference at all in states rules. So that's something we can talk about in the future too. And I noticed in our chat and in our question and answer columns that there are a lot of very knowledgeable people in the audience about Section 5057. And so I'm really looking forward to the conversation as soon as we get done with Stephen, who is our next presenter. And there's been a lot of comments here about sign language, and I know that's because we invited Stephen. Stephen Kramer just earned his PharmD from St. Louis College of Pharmacy at UHSP, and he has a passion for American Sign Language, and he has started American Sign Language Club on the Tallow Career Exploration website, encouraging people to consider sign languages when they're talking about career opportunities and so forth. And then he also has done a lot of work in coordinating disability health fairs to increase health literacy for those who have disabilities. And so, Stephen, thank you so much for joining us. I am glad that you can share your student and professional experience so far, and your insights into more access in the pharmacy from your perspective. So go ahead, take it away.
Hello, my name is Stephen with a V for Victory. I am a graduate from St. Louis College of Pharmacy as of last Friday. Woo! So I'm very excited. So a little bit about my story. In 8th grade, I met someone who was deaf, and I started learning sign language. As a senior in high school, I found this research by Dr. Mackenzie Ferguson, who is also a graduate from St. Louis College of Pharmacy. where she met with 20 deaf individuals. 8 of them said they used trial and error to figure out how to take their medicine. All 20 of them said it's basically a waste of time to talk to their pharmacist because of that language barrier. And often what they would do is they would add little markings on the bottle, and that's how they would learn how to take their medicine, by guesswork and side effects. As when you could imagine, that's not ideal. And that really inspired me to start the PharmD journey that I've been on since graduating high school, to advocate for the deaf community.
Okay, great.
So at St. Louis College of Pharmacy, I had the opportunity to collaborate with SNAPA, Student National Pharmaceutical Association, which is a national pharmacy organization. They have the student version and then the national organization, which is serving the underserved with the mission of one mission, no barriers. And with the sign language club that I started at Still Cup, we were able to collaborate with Centers for Independent Living, which are located across the country. These organizations are available 24/7, 365, creating that trust in the community as they are led by people with disabilities. And we had pharmacy students working with sign language students so that the pharmacy students could practice working with an interpreter, like looking at the patient and not asking the interpreter to say stuff to the patient, as well as allowing sign language students to practice their medical sign language in a controlled, supervised environment, because we had both pharmacy preceptors and ASL interpreter preceptors. So that was really exciting. So I would definitely recommend checking out your local Center for Independent Living. And what I'd like to see is SNAPA and other pharmacy organizations collaborate with those Centers for Independent Living, because then you're empowering this organization that's there 24/7 to advocate for the deaf and people with disabilities. And then the 2 pieces of feedback that I definitely wanted to highlight from the deaf community, from the pharmacy perspective, both in the retail / outpatient and then hospital / clinic. In the retail setting, members of the deaf community have shared with me that they're really appreciative of their pharmacists, because they take the time to make sure that the deaf that communication can occur, that they write stuff down, they look at them, letting them read their lips. I should clarify, not all deaf people know how to lip read, but making sure that communication happens. So the feedback provided by the deaf community from the retail setting is there's a lot of multitasking that happens, which, as someone who's worked in a retail pharmacy, yes, it's the middle name of any pharmacy. Making sure to talk to making sure to focus on finishing the conversation, or saying, hey, 1 second, I need to do something, not trying to verify prescriptions or organize prescriptions while communicating with the deaf patient, because if you look away, they can't see your lips. So it makes it difficult for them to lip read. So that was the biggest feedback I have from the retail setting. On the other hand, with the hospital / clinic setting, the feedback provided is have an interpreter in person. And as Joanna kind of mentioned, if the deaf person requests an interpreter, make sure that the interpreter is there for the appointment. I'll also add, with the little tablets, the VRIs that have the interpreters on the tablet, members of the deaf community have shared that when those are used, it feels like it's the first time that they've been used before. Like the provider doesn't know where they're at, doesn't know how to turn them on. Maybe they're not charged or connected to the internet. So there's a lot of process required to turn on those devices while the deaf person is there. And even if the provider was planning on speaking to the patient for only 5 minutes, because the first 10-15 minutes was spent getting the device ready and then communicating with the patient, it gives the impression that a portion of the time that the provider was going to give to supporting the patient was used to get the device ready. So my recommendation in that regard is making sure that one knows where that device is, that it's charged, plugged, you know how to turn the volume on. And I would even suggest turning it on before you enter the patient room, getting contact with the interpreter and making sure that the interpreter can hear you before you go in. So that way, even if it is that 5-minute meeting or however long you're meeting with the patient, that way you're not incorporating the getting it set up and ready to go. And then the deaf person is like, they did all this work for 5 minutes. Why? What's the point? Why are they doing this? And then the other thing that members of the deaf community have shared with me in regards to the tablet is making sure that the interpreter on the screen can see both the provider and the patient so that the interpretation can incorporate body language. They shared that like when they're laying on the bed, like so, because of whatever reason, either propping them up so that they can more effectively see the tablet or the in-person interpreter, and then also see the provider, or even better yet, having one of those swinging arm things so that you can adjust the tablet to show both the patient and obviously their hands as well as the provider. A lot of times the patient has to look at the provider and look at the patient, look at the interpreter, and it causes a breakdown of understanding and communication. So those were the two feedback that I had, that I definitely wanted to highlight, and then collaborating with Centers for Independent Living. So yes, thank you so much for having me, Sharla.
Thank you, Stephen. I love this idea of having the interpreters and the student pharmacists training together at the same time so that they are all knowledgeable about how that process works. I think that's an amazing point to make. And I hope that model spreads. And I think that's something that us as advocates can just continue to encourage that idea, so that I know that both sides are equally trained to do that. So thank you so much, everyone, for joining in. And because we have such knowledgeable people attending, I'm really looking forward to the comments here. So I'm going to start with our Q&A, and if any of the presenters want to pop in and say that, and then if you were the person who put this question out there, if you want to raise your hand and join in the conversation, I will allow you to talk, and so you can be a part of that. So Jim House said, what efforts has the state or pharmacy industry made to bridge communication gaps to people who are deaf or hard of hearing, such as remote video interpreting, to eliminate the process of searching for interpreters at the last minute, or videos in ASL on how to properly take different medications and which side effects to monitor for? So in my experience, I mean, I'm not a pharmacist, but I have heard a lot of stories about people having to wait a long time. And so, what efforts have been made? I honestly don't know if there's a huge amount. So I'm hoping maybe some of you that have more experience in that could say that. I think the idea of having video instructions is amazing. And I've actually, after talking to Stephen and stuff, brought that up to our company, research and development. And so, we're playing around with that idea and how could we make that possible? It's not a reality yet, but you guys have planted that seed in our mind. And so, I think, with technology, lots of things are possible. So maybe, does anybody else want to address what they've seen in the pharmacy industry for ASL? Steve?
So I will say I connected with an organization called VUCA Health. I mean, they have merged with another organization. I don't remember the new name, but it's VUCA, VUCA Health. And what they have done in the past is they made video recordings of medication instructions, and I have watched the videos. They're quite insightful. And what it is a little QR code that the deaf person would scan with their phone, and it pulls up the video. As of right now, I had the opportunity to meet with the leadership, and as of right now, they're working on recording interpreters and then using chat GTP and AI to create an algorithm that the AI uses to, like, jigsaw puzzle, you could say, the actual human interpreters. I haven't heard more on that, so I would have to direct further questions on that to VUCA Health directly, because I personally am not involved with what they're doing. But I thought it was a fantastic idea. They have this library where even if you don't have the barcode, you could go to the library, search your medication, and it would have a video. I would say they had about 30 videos. So obviously not every medication was in the library.
Yeah. It's probably not possible to all, but
Exactly.
I think
And I
that
think that was one of the things that was kind of like a roadblock, you might say, because they realized the logistics of making an ASL video of every single medication was not feasible at the time.
I would imagine it'll end up being, oh, Jim Lowe, put you in on this. It will end up being kind of like how we are training for our dual language labels. So we do utilize old-fashioned AI, but we have trained pharmacists, and I saw one of them is even in the chat here, or in the viewership, that help to train our AI. So there's about 600 words that are in the most common SIGs. So what we do is we have bilingual pharmacists help train our AI to appropriately translate those 600 words. And then our AI can help a pharmacist create a SIG. If it's not a non-traditional SIG, they can still create a SIG in another language, because we've trained our AI on those 600 most frequently used words. And then, of course, the SIGs that are most frequently used are already translated and available for a pharmacist just to pick it from the list, the drop-down list, and choose, this is the translation I want to use. So they don't have to know that language. Jim, did you want to add anything else? I think I gave you permission to talk. You just have to unmute. Oh, okay. He said that he's not able to speak right now, that because he needs an interpreter. But And I don't have it set up for them to show camera. Sorry about that. I did not think about that as needing to have everybody enabled for cameras. He says many doctors use video interpreters. It works if you have a good internet connection. Oh yeah, that the internet connection is always a hard thing too. Yeah, and then he says, but like Stephen said, not all patients can use them effectively, especially those who are deafblind, right? That the deafblind is a whole separate issue. We actually do have a solution for deafblind prescription labeling because our script talk can be exported to a Braille display. So if they know sign language, or if they know Braille, which, you know, of course, not everyone knows Braille, even those who are deafblind, because it's a process to learn all those new things, right? So thank you for pointing all that out. So let's go on to the next question. The pharmacy process has become challenging as management is built around the profit model. I wonder often if pharmacists see themselves as a crucial member of the health management team. I've questioned the pharmacist addressed in a letter to the CEO emphasizing the importance of accuracy and timeliness in distribution of pharmaceuticals. There is a need to reform the pharmacy process, including requiring lot numbers on bottles. Is there a recognition for how the current process has the potential to do harm? I mean, in my experience, the pharmacists themselves are they're very concerned about their patients and their patient health and the processes, but it's really when you become part of a larger organization that things become difficult. And I mean, of course, the big pharma is like this huge industry, and a lot of it is controlled by people that are not the pharmacist. And a lot of them feel like their hands are tied. So yeah, writing letters to CEOs might be the best way to go about it. And I do know, you know, with the national class standards and stuff like that, there's really a push for companies to have policies and procedures in place. And then also evaluation. So I think as those standards become more and more entrenched, that might improve. But unfortunately, like when you have a huge multi-layer industry, that's hard. It's hard to make changes in a big industry. Does anybody else want to address any of that?
Yeah, I wanted to add a little bit into that. And from my experience, the answer is they are definitely not part of the health management team. And I feel like that's happened. I mean, we moved a lot towards, you know, interdisciplinary and multi-management teams in healthcare. So we're starting to see a lot of, you know, caseworkers and things like that happening. But as the interpreter is not part of this team, pharmacists are not. And in addition to what Sharla said about, you know, being such a big industry and so many players and things like that, I think one of the issues is that a lot of pharmacies are not connected within healthcare systems. So that really doesn't allow a way to communicate and add them as part of, you know, the management team of any patient. So it's very, unfortunately, I feel like it's very hard for that to happen anytime soon. It's kind of like the same thing about us not sharing within organizations medical information of patients. There's a lot of things that we have to, you know, put together before we can really even think about the pharmacist being part of the management team, which is unfortunate because they should be, of course. We should all be communicating one with the other. You know, the pharmacist should be contacting the doctor and be like, hey, this person didn't refill. We already contacted them 3 times. They ran out of, you know, blood pressure medication over a week ago. We don't know what's going on, right? So we should be having that type of communication, but the system is just so complicated, so many layers that I just don't think that it will be a little bit better if the pharmacist within the health system, if there's a small pharmacist within, you know, the hospital or clinic, but that's not really the case on many of them. So it's unfortunate because they know the harm that's happening. Same way as interpreters, we know what's happening, but we have no voice. We're not part of the team. And that's one of the things I tell, you know, the providers when I work with them. I want you to think about the interpreter as part of your team, as a colleague, not an add-on. It's not like an extra thing you have to do. Oh, it's so annoying. It's going to take longer, things like that. It's part of your team. Just like you go and ask a cardiologist colleague for a consultation, your interpreter and your pharmacist should be that other colleague. Their specialty is just different. It's language and communication or medication. That's how they should be looking. And if we start seeing, like providers start seeing, interpreters and pharmacists as, as another colleague, then hopefully things will start changing eventually, but we are years for that.
Right. Yeah. Yeah. Janice, if you want to add more, go ahead.
Can you hear me?
Yes.
Okay. Joanna, what you just said, it just really it's disheartening. And what I have personally begun doing with my son, Stephen, with a V, who is part of the CILV community. I've begun using smaller pharmacies for his medications because there is a disconnect that can be quite harmful to him as a person who lives life with disabilities. And for those of you on this call who are in the pharmaceutical industry, we need to empower our pharmacists to become better team members. I know of an experience where in the doctor's order, it states that the pharmacist is supposed to make sure that the patient understands the directions, because taking this particular medication could be deadly. And I've seen pharmacists who take that time to say to a patient, have you used this medication before? Do you understand you cannot take it? You have to take it as prescribed. Why that is not more commonplace, and I get the big rush. I get they have so little time to do so much, but increasingly I'm thinking we need to look at some kind of policy or way to empower our pharmacists to become a more essential part of the team. They are vital. They are vital. Thank you.
Thank you.
And I want to just add something very quick before we move on to the next question, because I agree completely with what Jenna said. And another piece to this, especially when we're talking about medications that are so crucial and so sensitive, is that it's very important for us to continue to train providers on the importance of teach-back methods on low literacy, and making sure that before your patient leaves your hospital or clinic, they understand what they're supposed to be doing. Because as you mentioned, the pharmacists don't really have the time to be explaining this. They should be, just clarifying little things. Providers are the ones that should be ensuring that patients are leaving understanding it's 3 times a day, 5 drops, and not 3 drops 5 times a day, because that is, it could be life-changing. That could be serious, right? And that's one of the things we're talking about. It's teach-back methods, making sure, we talk to the patient with low medical terminology so they can really do that, and then following up with questions, not just leaving it to the pharmacist, but, a week after, calling them and being like, hey, did you go to the pharmacist? Do you have still any questions? How is that going? And that does happen, but it does not happen at the same rate for LEPs and other individuals that need language access. Most of the time, they do not get that follow-up. They do not get access to, their My Chart equivalent. So they are pretty much locked out of, your appointment is gone. That's it. We'll see you next time. Figure it out. And that's very unfortunate, Jess. Thank you for sharing your story.
Yeah, for sure. Next we have William. He was just talking about Title VI and the Affordable Care Act, Section 5057. Yeah, so they make it clear that pharmacies are covered, but why do we still see such low compliance? And also, just as a follow-up to undue burden, that Department of Health and Human Services rarely recognizes that as a good excuse. My first response to this is, the thing is if you're blind, low vision, has some other disability that makes technology impossible or difficult, or you have limited English proficiency and don't navigate government websites very well, actually filing a complaint with the Department of Health and Human Services is a difficult thing. Most people are like, you know what, I'll just accept it for what it is, and rather than press. And then a lot of patients I've worked with are like, but my pharmacist helps me so much. I don't want to get them in trouble. I don't want to, if they feel like it's a burden, I don't want to be a burden on them. And so they just don't pursue it more.
Yeah, and thanks for that. There are a lot of different threads to pull out there. The first is, I think people misunderstand. Can you guys hear me?
Yes, keep going.
Yeah. People misunderstand the issue of standing with respect to filing a civil rights complaint. If you have material knowledge, at least under Title VI, and actually under Section 1557 of the PPACA, if somebody has material knowledge of somebody else's civil rights being violated, they can file a complaint on behalf of that individual or of an affected group. And that's an area where, so I do a lot of work nationally on language access with the Association of Language Companies, the National Health Law Program, the National Immigration Law Center. And, we try to educate limited English proficient populations. The RID tries to educate deaf and hard of hearing populations that there are ways of requesting access. I've had very senior people in the OCRs of DOJ, HHS, Department of Ed say point blank that cost or burden is a very tough, tough way to get out from under a Title VI complaint or a PPACA civil rights complaint, because the reality is there's a language industry out there 24/7, 365 to provide an interpreter virtually in ASL and 300 plus spoken languages in a relatively short period of time. Larger pharmacy, the big chains, because I think those are big targets, tend to have resources available, although whether those are actually used, the point of sale is another question.
Right.
There's extensive literature going back now, the better part of 35 years, that the provision of language access, quality language access, correlates highly with better patient adherence. And that's what we're really talking about with respect to pharmacy instructions. And I think it was Stephen with a V talking about deaf and hard of hearing patients performing medical experiments upon themselves to figure out how to use their medicines. There are medicines out there where that could be exceedingly deleterious, right? If you're taking a type 2 diabetic medication and you end up having a significant hyperglycemic low overnight because you took too much of your basal insulin dose, your Lantus, you might not wake up in the morning. Might wake up a vegetable. And so these are real life and death issues that it seems to me the pharmacy community, the pharmacist community, could do a better job on. It doesn't really cost that much to provide language access. It's really not that hard to do. Title VI says no one shall be discriminated against on the basis of a number of protected categories. That's no one person. So saying that it's too hard to find an interpreter or a translator in a language of lesser diffusion is not going to carry much weight, at least at the national level. Maybe some of the regional CRs more lenient, but at the national level, that's not going to carry much weight. Or saying, oh, this adds a certain cost to the provision of service. Well, the theory behind the enforcement of Title VI, you don't get paid to not discriminate. You're just supposed to not discriminate. It's supposed to be built into your cost of doing business. So where I'm coming at this from is just sort of hearing these arguments posed as barriers. And I understand in the real world, language access is something of an unfunded mandate. It becomes a cost center to minimize, with the exception of the very small number of states that are taking the partial Medicaid, not Medicare, but Medicaid reimbursement for language access. And the small number of states like Oregon that have supplemented that with state funding. But there's 2024, there's 70+ million Americans who speak a language other than English, something more than 5 million deaf and hard of hearing Americans. There's no excuse. There's just no excuse. I'm sorry to go on my soapbox on that, but there's no excuse.
Yeah.
Anyhow,
We
thanks.
all agree with you. So thank you. Thank you for.
But it does become this question. So I was in Washington County, Maine, a couple of weeks ago, working with a community-based organization and hearing horror stories of, oh, we go to the pharmacy, and these are folks who speak from Central America and Southern Mexico, so they speak Spanish, but they also speak Zapoteco or Cantabala, Quiché, or Mam, or whatever language, and they're not getting language access when they go to the pharmacy. Even if there's a point to your language, the I Speak charts that were that come out originally out of the state of Washington in the early 90s, and the pharmacist just not picking up the phone and dialing the 800 number for whatever language line service they have and getting somebody to provide an interpreter. That's just not going to do it.
Yeah.
And that's on its face a civil rights violation. And the way I read 1557 and the implementing regulations of 45 CFR 92, pharmacists are covered entities as long as they are, the moment you fill a single Medicaid or Medicare or market plan or VA prescription, you're a covered entity. So,
right.
And that one prescription makes you a covered entity. Anyhow, I'll be quiet.
Thank you so much for your contribution. We do appreciate that. All that is a really great point. So our next question was from Jamie Thompson. Let's see here, Jamie, I'll allow you to talk. The question was, do you have any recommendations for LEP patients or folks assisting them, such as case managers, when they encounter a lack of language access at the pharmacy? So I think, William's recommendation is there, file a OCR complaint, but maybe before that, really ask for accommodations. I mean, that's the first thing a lot of people don't ask. But do you want to say anything else, Jamie, on that question before we try and answer it?
Yeah, sure. Good afternoon, everyone. I appreciate today's discussion. I work for a state refugee health program, and we hear pretty regularly from case managers and clients about these barriers, including, they do request interpreters and are denied, and in some cases denied next to signs that say we're committed to providing interpretation services. We have worked a little bit with our Board of Pharmacy to essentially send a reminder to pharmacies about this requirement, relating to civil rights. I think it was William that mentioned folks should be able to submit complaints to boards of pharmacy on behalf of clients. That's something we've also encountered a struggle with, sort of how our state's form is, how the form is indicates that, you were supposed to be the person who's encountered the problem, sort of, and we brought that up and said, obviously, if they're not speaking English and this form is in English, this is not going to work well. So yeah, if you have any references that we might be able to provide relating to people being able to submit those complaints on behalf of clients, that would be helpful. Also recognizing case managers are very busy individuals and frequently don't have time to accompany clients to pharmacies or to submit those complaints on their behalf. So I appreciate these sort of systemic approaches. I really think they're needed. Thanks.
Wow, so much packed in there. Yeah, I think one thing you made a good point, like a lot of people do not know that they can file a complaint with their state board of pharmacy. And so that's always a first a second option. I mean, the first option is to actually, you know, address it with your pharmacy and be like, listen, there are these laws and you are not following them and you need to be compliant. And then if they're like, too bad, then, you know, State Board of Pharmacy, you also have your State Human Rights Commission, you have
Or
Department of
your
Services,
state
those
law,
are-
or your state lawmaker, right?
Thank you. That's a great point.
Yeah, I mean, I'm sitting here and I'm hearing these and I'm kind of shocked, right? So I don't know what state you are in, Jamie, but I would recommend you contact your state lawmaker. You know, I troubleshoot that on a regular basis when my constituent call me, and they don't even live in my district sometime, but they call me because they know that I champion language access, right? So obviously count on your state or local elected official to help you with that grievance, because the more that we hear about it, and that's what I was going to say to a couple of the other speaker too, is that if you regularly talk about your story, talk about the struggles that you have, because people assuming when they don't hear, and lawmaker, when we have like thousands of bills to go through, when we don't hear everyday stories, we're not going to be able to make that decision. And it will help us to convince people on the opposite side of the issue to understand that there's a human element to this, because a lot of times they don't hear it and therefore they don't think it exists. So I encourage you all to contact your local lawmaker or state lawmaker and make sure that they get involved. So that's what I would do.
You know, we talked a lot about legislation just because I'm in public policy, but obviously there's a lot more work that can be done on the advocacy side, even before we have to take that step. So please follow us all on LinkedIn, continue the conversation. If you have other questions for each one of us individually, you know, email us, and I hope to see you all again at our next event, whatever that's going to be. I don't have it planned yet, but we certainly have a lot of work ahead of us and a lot of people to help. So thank you all for joining, all the guests as well as all the panelists, and have a great rest of your day.